The thing with digital health is we have the opportunity to remove that one-size-fits-all. We burden our minds and our time with the biggest problems we have. And if we spent our time solving all the little problems, which are more easily solved, we'd free up a lot of time. The NHS has been around now 75 years.
Yeah.
We've got more people, more tests, more treatments than ever before. But the model hasn't really changed. We need to go back beyond that. We need to be accessing people prior to them coming to doctors or hospitals. We have a number of different products, but it's about the platform technology that we're using. When it comes to home users, it's about driving confidence in their understanding, holding their hand through the process. After we implemented ClearScreen for them, which was a system that allowed them to scan lateral flow tests, overnight, they went from only around 30% of patients coming in being tested and only 15% of those results getting into the patient record to 75% of patients being tested and 98% of those results getting into the patient record. And I think this is the benefit that scientists can have within the NHS is understanding these dynamics of large numbers. If you can save 1 minute for every patient that walks in that door, just one, but 1 minute per patient, over the course of a year, you've saved 100 days. We're working with Mid and South Essex Trust to produce a new model for delivering prostate cancer screening where kits. It's a new model, this new idea of being able to, instead of moving people, moving information.
Welcome back to Inside Health Innovation, the podcast that digs deeper into healthcare's innovation boom. How can we harness the technology in your handheld smart devices to deliver clinical-grade diagnostics? I'm Karina Malhotra, the Managing Director and Founder at Acumentis. And today, I'm talking to Andrew Botham, Co-Founder and Chief Scientific Officer at TestCard. TestCard believe that the future of diagnostics is digital. But are there any challenges, opportunities, or indeed risks with this approach? Let's find out. Hi, Andrew. Nice to have you with us today.
No problem at all. It's good to be here.
So nice to have you. And I know you've got some things to show us later in the show as well. So looking forward to that.
A couple of visual aids.
So, Andrew, we're going to get started with my favourite question, which I always start these episodes with, which is, what does the word innovation mean to you?
I suppose really, for me, innovation is a way of looking at things, really. And I think we've seen an explosion of innovation, but I think what we've seen is an explosion of the language of innovation rather than innovation in and of itself, if that makes sense.
Yes.
I think we use it a lot in day-to-day. I think the NHS especially has tried to drive a lot of innovation, but sometimes I think the issue is less. I don't think there's ever been a shortage of innovation. That isn't the problem. So although we have some absolutely brilliant innovation acceleration programs within the NHS now, which are incredibly valuable, there's never been a shortage of people trying to bring new ideas to the NHS. The issue has always been the capacity within the NHS to be able to adopt them, develop them, and make them their own. And they're very busy in their day-to-day jobs.
Yes.
So, just opening a door and trying to squeeze hundreds of people through it doesn't make it any better. But no, I think for me, innovation is about looking at things in a new way. And in every industry, and I think in every situation, I don't want to sort of labour on the NHS, but I think everywhere, quite often, innovation or improvement looks like doing the thing you're already doing, just slightly faster and slightly cheaper, and maybe the equipment's a bit smaller. And that's not innovation.
Yes.
But people are very comfortable with doing the things they're already doing. They own the problems they already have, and they don't like the idea of having a new system that has new problems that they're not familiar with.
Yeah, that's right. So you've talked about, obviously, that scenario where just doing things slightly differently may not be innovative enough, perhaps. So what is it that makes it real innovation then? Not just sort of, sometimes, and I think we talked about how just turning a paper process into a digital process, yes, adds some benefits to the system. But is that really pushing that boundary? And what would get the NHS to that boundary?
Yeah, so like I said, in terms of digital health, I think digital health especially offers so many opportunities for improvement or innovation. But quite often what you see is taking existing systems and digital, making them electronic rather than digitalizing them.
Yes.
And it fails to accept all of the opportunities and tools that are available to them. They want to use a different tool, but in the same way as they've already used the old tool that they've got. So it fails to accept that all the other things that we have. We do have, in many cases, a one-size-fits-all healthcare system. That happens because we want to keep it cost-effective. We want to make sure that it works efficiently. And in many cases, the best way of doing that is one-size-fits-all, where you have to be at this place, in this way, at this time, with this person to get this thing. The thing with digital health is we have the opportunity to remove that one-size-fits-all, both for the individuals that are taking, who are being treated in that system, but also for the clinicians and services that are using that system. We can have a single gold standard destination, but have multiple routes and pathways into it, which work better for those systems and for those people. And that's innovation for me. It's accepting that you have an entirely different kit of tools available to you than you had before. So you should use all of those tools correctly. Trying to use a hammer as a screwdriver isn't going to work.
No, absolutely. That's such a great answer. And it made me think when you talked about how it's not just about digitizing the same process and calling it innovation. Innovation is perhaps much more than that, which is about sort of exploring what other tools can be utilized. So obviously your background, Andrew, is as a scientist and as a scientist in the NHS. Tell us about your transition into becoming an entrepreneur and perhaps what your background as a scientist has been brought with you.
I'm not entirely comfortable with the moniker entrepreneur. It gets put on me a fair bit because, I started a company, so that's my own fault, I suppose. But the window in which I look at the world is very much a scientific window. I am a scientist. How I approach my life and my work is always as a scientist, which is to try and look at things empirically, take them apart and put them back together, in troubleshooting and understanding the way something works in order to redesign it or improve it. I think for me, if you were to distill down what describes an entrepreneur, it's about recognizing opportunities and doing the things to capitalize on those opportunities. Now, in most cases, when we're talking about entrepreneurs, they are commercial opportunities, they are commercial gains. But I think you can have an entrepreneurial mindset in whatever you're doing in terms of seeing an opportunity and seeing that opportunity as a means of developing or improving what you're already doing. So I think you can link that with any industry. The fact that I'm a scientist is perhaps secondary, but it meant that within my field and within what I do, I had the right background and the right knowledge to be able to recognize where those opportunities are and minimize the risks whilst optimizing the benefits of doing those things, which is what I suppose an entrepreneur does.
Yeah, and it's interesting because, as you say, you look at the world quite empirically and try and problem solve. And, one could argue that's what an entrepreneur is doing as well. So it's quite a nice segue into that. I appreciate maybe that's not a moniker you're comfortable with, but we can see the kind of sort of transition is not too difficult, I guess.
I know. I think it's about stepping out. Again, it goes back to the innovation thing. There's a lot of overlapping here. There's a very complex Venn diagram, I'm sure that someone will happily draw. But it's about stepping outside of the system that you're working within and recognizing that other systems are there.
Yes.
I think that the difficult part isn't always recognizing the system and designing a new system. The difficult part is getting from one to the next, is finding the correct route or path from one to the next. And the entrepreneurial mindset is very much almost drawing a straight line and going, well, we're just gonna go there. And it's that not being afraid of failing, not being afraid that it's not going to work out the first time. The old adage of getting up one more time than you're knocked down. And I think that's the difference with the entrepreneurial mindset, whereas I suppose science has always been improvement by gradual steps, rather than sort of saying, no, we're going to take this thing, we're going to scrap this and build something new from scratch.
And then based on what you just described, the sort of, entrepreneurs like to, or not like to, but entrepreneurs are comfortable with failing and getting up again. Scientists are also heading in a similar direction to solve a certain problem, but might do so gradually and maybe not as fast, perhaps, or rapidly as an entrepreneur would like to. What do you think our healthcare system needs more of then? Do we need more scientists? Do we need more entrepreneurs? Do we need a balance of both?
I think we could do with a more entrepreneur mindset in some respects. I think within the NHS, it's very important to find a way of failing safely. And I understand they have a very low risk appetite within the NHS, and that's that's entirely understandable, given that we're dealing with people's lives and their health. But I feel that there can still be cultures, and there can still be ways in which failure can be considered acceptable when you're doing new things. Effectively, when you're innovating, if you want people to innovate, you have to accept that what they're doing is inventing. And no one has 100% of their inventions ever work. And no one has their inventions work to 100% of what they can possibly do. So it's about just creating a safe environment for general day-to-day workers. People are on the shop floor all the way up to management, where they can say, do you know what, I think we should try this. Let's find a way of doing it safely, that if it doesn't work out, it's not going to impact on patients, it's not going to impact on staff in a negative way. But do you know what, if it doesn't work, what happens is someone turns around to me and says, oh, that didn't work, but what's your next idea? What did you learn you're not going to do next time? And let's go again. Let's go again.
Yeah.
And it's about having that appetite for failure and making it safe for them to do it, and not feel that it's going to affect their career progression. They're not going to be judged negatively for not 100% delivering on something 100% of the time. Yeah. And I can sit here and say that very easily. I don't know how to do that. But I think that's what's necessary for people to start being willing to step outside of the circles of the systems that they work within, and to do new things and try new things.
No, absolutely. I mean, I've worked on the front line, as it were, not as a clinician, but more in the management side. And I think that is so true. Failure is not, done safely in the NHS. And quite frankly, I mean, there's plenty of stories of something goes wrong in a hospital, and, senior members of the board either have to resign or things like that. So there is a lot of pressure. But you're absolutely right. I mean, if there was an environment where that kind of safe failure was possible, just imagine the number of ideas we could be testing. And it's really interesting because in the absence of that, obviously we have, innovation networks now that are trying to bring new innovations. But I find certainly the innovators I speak to, and it'd be interesting to hear your experience, that it's not always easy to get that test environment in the NHS because of, again, the risk aversion. So how do you bring your innovation to the NHS if not many people are interested in testing it out? Do you know what I mean?
Yeah, and I think it goes back to what I was saying earlier in terms of there being a language for innovation, but not necessarily a culture for it.
Yes.
And there's never been that shortage of innovations. It's always been the adoption that's the problem. Now, we've been very fortunate in a couple of cases where we work with some fantastic people within those NHS trusts. And it's about having that champion. And it's about having there being a willingness to do that work, to take that risk, to put their head above the parapet within their institution, organisation, and them to champion it. Now, the problem we have then with those innovation networks is they bring lots of people to the NHS, but they need one of those champions to take it up. And what happens is, you have a champion, they work with you, but they end up having the thing that you've worked with and continue to have that as a burden. It becomes a thing that they continue to work on. So they don't get freed up for the next innovation that's coming in.
Yes.
So I feel that the best way to adopt greater innovation is actually finding those people that have that mindset, that have that have that means and willingness and ability to champion new projects. Allow them to champion a new project, but then after 6 months say to them, okay, you've championed it, you've brought it in. Now we're going to hand these off to people that are really good at embedding and maintaining projects, and we'll take you off of that and put you to the next innovation,
Yeah.
because you're a champion who brings new people in, because they're different skill sets.
Yes.
They are different skill sets, and you're burning an amazing resource within your institution by having them continue to maintain something when they've got exactly the right temperament, exactly the right skill set to be bringing new things in.
Yeah.
So I think there's no additional real needs in terms of recruitment or anything. It's about really recognizing these champions of bringing stuff in and removing burdens from them once they've brought stuff in.
Yes.
Freeing them up for the next thing.
Yeah. No, that's really good advice. Back to perhaps the innovation networks. There's never been a shortfall of innovation in the NHS, and certainly not today. We are sort of talking to so many different innovators, there are hundreds out there and some great ideas out there. I guess if you are that champion or the Health Innovation Network, or indeed a hospital or an actual provider, NHS organization, how do you think they can vet which innovation they should give time to and test out, and that sort of give them that opportunity for experimenting it? Because the challenge I find with organizations we speak to, because we do a lot of work on the front line still, is they get contacted by 10 different companies who roughly do something similar or slightly different, or how do you think they can choose which one to support and which one not to support?
It's a tough question. I think I go back to saying there isn't a shortage of these people out there, and the innovation networks work very well in terms of bringing these in. The accelerator programs do a lot of that vetting for them.
True.
I think the difficulty can be at times is, like you say, is then who do we talk to and what do we do? I think some of that can be done by defining what their problem is.
Yeah.
Because at the moment what happens is an NHS body, an accelerator program will say, well, what problem do you solve as a company, as a business? What problem do you solve? And then they try to find people with that problem.
Right.
And I feel like sometimes it would be easier for the service to say, here's a problem that we have.
Yeah.
And these innovation programs, these accelerator programs, could link them with the businesses that have those problems. They could be like a dating agency, it could be like speed dating.
Yes.
That does predicate, though, that the system understands the problem that it has.
Yes.
In some respects, and I think sometimes what happens is we burden our minds and our time with the biggest problems we have. And sometimes the reason they're the biggest problems we have is because we can't solve them.
Yes.
And if we spent our time solving all the little problems, which are more easily solved, we'd free up a lot of time, in which meant that those big problems would no longer be problems because we had time for them.
Yes.
So it's a chicken and egg, really.
It is a little bit.
So that's a really long way of saying I don't know.
No, I actually think that makes perfect sense. You're so right. There's a lot of firefighting in the NHS where you're sort of just dealing with the problem in front of you on that day, or you are dealing with the biggest national priority that you're getting pressure for. It might be a national target or national financial sort of direction. So you're so busy dealing with either your day-to-day problem of there's a fire in the theatres, or you're dealing with those national priorities and all that in-between stuff, which is where I think you're right, that if they solved about 10 of those middle problems, it would help on either side as well. That perhaps doesn't happen enough of. So no, I think I completely concur with your assessment of that that question. So let's move on to TestCard, Andrew. So tell me how a conversation over what I remember you were saying were 2 bottles of wine at least. Did you end up talking to a potential co-founder about this idea, and it turned into TestCard, a week later?
Yeah, they weren't a co-founder, they were a friend. Actually, went to the same school together. We were having a family meal at their house. I think it was a Sunday roast. and there were a couple of bottles of wine and a conversation about how bad men were engaging in healthcare. Men are absolutely appalling about doing the things they're supposed to do when they're supposed to do them. Women are much, much better. And my co-founder is someone who would be reasonably described as an entrepreneur. He's someone that has started a number of businesses and done some amazing things. And Luke Heron, by the way.
Yeah.
He and I think it was within a week or 2 weeks, he came and said, that conversation was an amazing conversation, and I think we should do it. Do you want to do it? I've come up with the name TestCard. So the name's him. The brand's he wrote a massive essay about the trademark, so we managed to get the trademark TestCard. And he said, do you want to do it? Let's do it. And
so you said you started the conversation was about how perhaps reticent men are at sort of dealing with or accessing health services. How did that turn into an idea for a business?
I'd had an idea during while I was doing my PhD in medicine around home screening for prostate cancer, BSA, and we were talking about that, and we were both coming up to our 40th birthday when we get a letter from the NHS inviting us to an intimate digital examination, and it came a question about there must be a better way of doing this, and I think the conversation then become larger after the fact about what barriers exist for people to be able to engage in healthcare. It isn't always the right thing to drag people from a safe, secure setting into a healthcare setting. And certainly, I mean, you've worked in operations within hospitals. There's a real recognition now that bringing elderly, frail in through the emergency room is not the right thing, because once they're admitted to hospital, it actually is detrimental to them in the long term.
Indeed.
And we need to find a way of being able to intervene in healthcare to provide that different model. Because despite the fact that the NHS has been around now 75 years, we've got more people, more tests, more treatments than ever before, but the model hasn't really changed. You've still got to get off your couch, you've got to go to a GP, or you've got to go to an emergency room and say, hey, I want to be in healthcare. And we've had a revolution in point of care testing. But point of care testing speeds up pathways in healthcare. They have to get there first. It hasn't really shown any great improvement in healthcare outcomes because they're doing it in healthcare. So we need to go back beyond that. We need to be accessing people prior to them coming to doctors or hospitals.
Yes.
And in doing so, we're ensuring that people who might not have come before come earlier. And if they're coming earlier for need, we've identified that they need to be there, then we're potentially diagnosing conditions much earlier and improving outcomes. But we're also preventing people that don't need to come in and giving them confidence in both cases that they're making the right decision.
Yes.
And the first interaction then that person has with a clinician is one in which the clinician actually has some empirical data, some evidence to work on, rather than it just being an entirely a conversation. And that makes a big difference if they already have something to base any sort of further conversation that they're having on.
Yeah, no, that makes so much sense. So after you formed this company, a couple of weeks later, you started working on an MVP, I understand, for a good couple of years. How did you manage that professionally and personally? Because you were doing almost two full-time jobs at the same time.
I was pretty much doing two full-time jobs. I was working around 50 hours a week for the NHS and had small children. And so basically it was evening, weekends and holidays. I didn't have all of my holiday time, all my annual leave for the NHS was spent doing time for TestCard. So it was a very tiring time, but it was incredibly rewarding in many ways. It was because working for the NHS can be very rewarding, and you feel that there's a great value in what you're doing just by virtue of working for the NHS. But things don't move very quickly. Whereas with working on the startup side of things move lightning fast. The flexibility and nimbleness of working in that culture. So I felt like I had the best of both worlds in working in my day job for the NHS, doing the things that take a really long while but have a high value, and then working the rest of the time in a startup where I can do things like turn on a sixpence and and realize new things and change things so very quickly. It was perfect. Especially as a scientist, be able to say, no, we need to change this and do this and expand that and reduce that and get rid of that. It was fantastic.
How did you manage it? And what kind of, I suppose, what drove you through a good couple of years of hard labor?
I think because I could see where we were going. It's always felt, and I think this is the thing with startups is, having spoke to a lot of startups, they'll tell you if I realised it would take this long, I wouldn't have done it to start with. It's always the success or the payoff is always just over the next hill, but there's always another hill. So it's always felt like we can see the light at the end of the tunnel, but the tunnels continue to get longer as we've gone along it.
Yes.
I think it's been very good working for TestCard, and the reason I think we have so many fantastic people working for us is because there's never been a difficulty in communicating the value to people. We've won lots of pitching contests and lots of trophies at the company showing that where we've won different pitching contests and startup contests. And perhaps it would be nice to think it's because I'm a good public speaker, but actually I think it's very easy to explain to people how this makes things better. Yeah. And we've got a very, very talented technical team that do our apps and our image analysis work and our integrations with different systems. And these are people that are incredibly good at what they do, but their opportunities in other sectors are making crypto exchanges or games and they feel working for TestCard, I may be putting words into their mouth. By working for TestCard, they can feel that there's a genuine value. There's that value thing. What they're doing, they're making things better. Yeah. There's an opportunity to make things better. Yeah. And you're not many steps removed from someone where this would have made a difference. Like the UTI test card, for example. UTIs affect 50-60% of women generally. It's around 3% of UK GP appointments are related to UTIs. With our products, you can diagnose. There we are. You can diagnose a UTI in comfort, convenience, and privacy of your own home. But you can also access treatment. So it's all very well doing the test, but you can actually directly access treatment through the app, where you can have that land on the doormat the next day. Or thanks to a patient group directive, they can go to a pharmacy and access treatment from their pharmacy if they wish to. Now, my nan, I don't know if you know this, but in the elderly, UTIs can actually cause looks very much like dementia. Right. And they become a form of delirium. My nan used to get UTIs on a regular basis. Right. One time she got a UTI, she ended up having a fall in her delirium, dislocating her hip, ended up in hospital, was catheterized in hospital. Wow. Then she came out, she was then on a walk-in frame and then had a bag because she'd lost continence. Then it happened again. Dear. And she went in and then she never came out after that and then died from pneumonia in a bed. Gosh. From UTIs. I know. Now, my mum was her carer. Yeah. And she would constantly have issues of being able to advocate. It's very difficult to advocate because you don't want to be dragging them out of the security and privacy of their, that safe place that they have into GP settings, into hospitals. Well, if you can hand someone a piece of evidence that, well, I've done this test, I know that they've got a UTI. Yeah. It empowers them in their advocacy. Yes. I'm not saying if that product was available, my nan would have lived longer. What I'm saying is that carers and people who need to access this sort of care in that way have a different tool now. They can still go to the GP. Yes. We're not, again, I'm not trying to replace one size fits all with a different one size fits all. Yes. What I'm saying is there's now an alternative that means that they have a means of being able to do this testing outside of GP hours within a convenient area within their own home and then access treatment should they wish to do it that way. Right. Yeah. No, absolutely. So tell us a bit more about how all the things that TestCard does. So obviously there's talk about the clinical grade diagnostic scanners that you're taking smart devices just like a phone and turning them into clinical grade diagnostic scanners. So tell us a bit more about that. And obviously you've talked about the UTI test kit, which I'm holding in my hands for those just listening. What other tests are you working on? How do they work? And any feedback you've got from the users? Yeah, sure. So I think that the key thing to understand is we have a number of different products, but it's about the platform technology that we're using, which is able to read rapid diagnostics. So any rapid diagnostic, colorimetric, lateral flow test, you can say lateral flow test now and people understand it thanks to COVID. But it's able to read them in a non-subjective way. It's able to read them and even quantify the results from them rather than provide just a negative positive, and produce a piece of raw data. And there's two parts to this, I think, anyway. There's the part that's the technology, and the technology is extremely good in terms of capturing the information. Mobile phone cameras now are ridiculous, largely driven by, people wanting to take pictures of their food, apparently. So mobile phone or pets, cats, isn't it?
Yes.
Mostly. Mobile phone cameras now are incredibly, incredibly good. And then our technology, which then balances, removes ambient and interfering light, and then is able to then convert that into a signal which tells us what the concentration of the thing that is being tested is present.
Right.
But then there's also an awful lot about the usability and the user interface, and it's understanding human factors and where mistakes and where shortcuts can occur. When it comes to home users, our UTI TestCard product and our products that we've done for home screening of cancer, they always consider the home user's point of view. It's about driving confidence in their understanding and what holding their hand through the process. It's not just having a big piece of paper, then there's all these instructions written in tiny font. There's a video showing them from start to finish, what they're going to need to be doing. There's just-in-time animations the whole way through, holding their hand and telling them you're doing the right thing at this point in time. For the UTI product, it even comes down to the fact that there's 2 tests in there rather than 1.
Right.
If you think this is the first time your first time you're using it, and you've got an opportunity to get treatment for your urinary tract infection, and you've got 1 shot at it, you've got 1 shot. That makes you feel more anxious. That increases your anxiety level. And the more anxious you feel, the less likely you are to feel that you're doing it correctly. Even if you're doing it perfectly correctly, you will feel like you're not doing it correctly.
That's so true.
So by having another test there, you have confidence that, I can just use this and see how it goes. And if it goes well, then you've got another test.
Yes.
But if it doesn't go well, you can do it again, or it goes well and I'll do it again and get the same result. And that increases that confidence. And you see this with, if you think of a test that's been in people's homes longer than anything else, it's pregnancy tests. Home pregnancy tests have been around for decades.
Yeah.
But still, the first thing a woman will do, having done a pregnancy test, is do another pregnancy test.
Buy a few.
And this isn't because they don't think that pregnancy test works. They don't think, it's on the shelf in the pharmacy, but it probably isn't any good. They don't trust their ability to produce such an important piece of information to them. It's going to change one way or another. Their life is going to be different.
Yes.
After having done this pregnancy test, and then the next thing they do is go to a doctor and have them do a pregnancy test, and the doctor's not going to do that test any better than the woman will. And I'll put money on the table to say the woman will have done that test better than the doctor, because they'll have read those instructions and followed them to the letter, because it is so important to them. So it's about driving that confidence and understanding the person's position in that case. And we learned a lot from working in the home market. And then when we started working with the NHS in professional use, it's understanding what their needs are. If you consider within a hospital environment, especially within an emergency room, nurses and doctors are being asked to have so many priorities. The word priorities didn't exist 100 years ago. We had priority, one thing, the most important thing. And it's not right to expect them to say everything is the most important thing. And they're just being given more and more and more. And to some extent, a point of care adds another thing that they're supposed to be looking after as well.
Yeah.
So when we developed that system, we did it in such a way that we looked after the integrity of the result. We did it in such a way that supported, and to some extent, it was the benefit of being able to work with an NHS service to develop that product. It was a collaborative development project, which meant that it looked after all of their needs. So then we were looking after the integrity of the result. They were looking after their patient, which should be their priority, the person in front of them.
And so just tell us a bit more about that collaboration. I believe this is the one with Guy's and St. Thomas's.
That's right, yeah.
And during the pandemic, and I've read the case study with some amazing results, so we'll be sure to post that along with this episode. But please tell us a bit more about the big difference using Clear Screen, which is the name of your platform, made to guys.
So during the pandemic, there was obviously a situation where they were having to mass test large numbers of people. And for that, they were using lateral flow tests. Relatively speaking, lateral flow tests are cheap, they're quick, they're easy to deploy, so it's an ability to scale very quickly and deploy them in different areas. The problem they have with lateral flow tests is they are, they were considered the poor cousin of the PCR test. The results weren't considered as reliable. They're difficult to control, and there's a massive iceberg of what's going on. There's a little bit at the top, which is, you sent out some tests, but once you've sent them out, you assume at some point someone's used them, and you assume at some point a result was generated, and some of those results might end up in the patient record. At that point, Guy's and St Thomas's were doing tens of thousands of lateral flow tests, and only around 30% of those results were ending up in the patient record. It may have been less than that. I'm going to go as far as saying it was 15% of results, and only 30% of patients that were coming in through the emergency room were being tested.
Wow.
After we implemented Clear Screen for them, which was a system that allowed them to scan lateral flow tests, so it identified the user, the clinical user that did the test, it positively identified the patient, it read the test, at the same time capturing all the Department of Health requirements, including lot number and expiry date of the test, individually identified the test, so prevented misuse and reuse of that test. It read it in a standardized, uniformly procedural way, and then directly integrated those results into the patient record. So it removed all that admin burden as well. Overnight, they went from only around 30% of patients coming in being tested and only 15% of those results getting into the patient record to 75% of patients being tested and 98% of those results getting into the patient record.
Amazing.
Which massively, also dramatically reduced the amount of retesting that was going on, because they weren't having to then, when they got to the ward, because there was no test in the system, having to retest them at the doorway getting into the ward. So it reduced the use of side rooms, and it reduced the hold up in that system. If you can control the front door within an emergency room, which is effectively what you're talking about, you increase the flow of patients through, which reduces those delays.
Yes.
And what we found, there was a load of benefits that were fairly obvious, now the results are going into systems, which is an improvement. We're reducing reuse of test and incorrect use of test, but then there are loads of secondary benefits that we didn't really expect, and they were things like the fact that we now had a piece of raw data, an image of the test, along with what we produce, which is a densimetric plot of the gel lane, to be able to identify how much of the antigen that we're testing for is there. They were able to refer back to it all the time. Right. For the first time, there was an actual piece of raw data rather than someone having scribbled something on a piece of paper.
Wow.
Which meant we had a reciprocal relationship with the users. And, you'll know in hospitals, sometimes when there's a mistake or when something goes wrong, they investigate it and they say, it was human error. And they'll go, okay, then we're going to retrain the person. And it in quite a lot of cases, it isn't the fact that they didn't know how to do it. It's at that point in time, they made a judgment call. They made a priority call. And as I said before, the priority should always be the patient.
Yeah.
If you've got a 10-minute waiting time on a test and you've got 10 patients waiting and you're on a 4-hour target in ED, are you going to stand there for 10 minutes and watch that test develop?
No.
Or are you, as soon as a control band comes up, are you just going to read it at that point? If you read it too early on these tests, you introduce false negative results.
Right, yeah.
The other option is you go, I'm going to leave this, I'm going to go off and do something else and come back in half an hour's time. Well, that introduces the option for false positive results.
That's probably what a lot of us doing these lateral flows at home were doing as well.
Absolutely. But because we created this system that controlled all of those elements, and we put the phones that are reading these in stands, so they could put the test underneath, hit a button, like add the sample, hit the button, it did the timer and then captured it at the right period of time, and then the results go across the patient record. And that produced a massive improvement in the quality of the results.
Yeah.
And what we found out over time is by supporting them and explaining to them why this was important, because now what we had is we could look at when there was discrepancies between the lateral flow results and the PCR results. We could go back to people and say, look, you didn't do this test correctly. Because of that, luckily we picked it up using our system. But if we hadn't picked that up, that you would have been admitting someone with flu or COVID onto this ward, which would have caused an outbreak. And it massively changes their understanding of the importance of doing these sort of tests correctly.
Yeah.
It isn't just about throwing a result out there and then getting the patient to the next step. So because we were looking after the integrity of the results, but also because we were able to report back and speak with, I say the senior leadership within that team, where they had a tool to be able to go back to people and explain why it was important. We saw over time the lateral flow results and the PCR results got closer and closer together.
Because they were doing it right.
Absolutely.
Because of the feedback you get.
So we massively improved the quality of how those tests were being carried out, and therefore the integrity of the result. So ultimately, Guy's and St Thomas's just scrapped doing PCR results for a large cohort of the patients coming in, which was a huge saving. I mean, I think the first tranche of savings was around £260,000 for them. But the benefits go beyond that saving, because by removing the PCR within their workflow, people were flowing so much more freely through the emergency room. But it also meant once the worst part of the pandemic disappeared, they were able to maintain that testing, that universal testing on their front door. Yeah. Because there wasn't a large cost for them to do it. Yeah. And that they were only trusting the company that over the next couple of waves didn't have hospital-acquired COVID and flu infections. Still to this day, on the front door of St Thomas's ED, when they walk in the door, within 10 minutes, they'll have a flu A result, flu B result, and a COVID result before they even finish booking them in. That's amazing. So they're able to flow them freely through that hospital. Brilliant. Now, as you know, and I think this is the benefit that scientists can have within the NHS, is understanding these dynamics of large numbers. I think Guy's and St Thomas's, if you look at the business, the busyness of their emergency department, of St Thomas's emergency department, if you can save 1 minute for every patient that walks in that door, just one. And this sort of solution save a lot more than that, because we're removing the admin burden, but we're also removing the need for PCR. You know, we're saving a hell of a lot more than 1 minute. But 1 minute per patient, over the course of a year, you've saved 100 days. Wow. 100 days. That's huge. Yeah. If you had to hand that back and say, here you go, we've given you time. Yeah. And that time compounds as well. And it goes back to a saying, if you can deal with some of the smaller problems, you make the bigger problems less burdensome. Yes. So by dealing with by saving time on every single patient, by the time you get to someone that's emergent, where there's a severe, where you have to do it, you see them sooner than you would have done. Yeah. And you have more time to spend with them. Yeah. Data genuinely save lives. Using data in this way genuinely saves lives. Yeah, that's amazing. That's a good statistic to take home from this podcast for sure. And that isn't sort of just obviously specific to lateral flows and those types of tests, because obviously now you're looking at a home prostate cancer screening kit as well. That's right, yeah. So our technology is applicable to any rapid diagnostic. And we worked a couple of years ago with Sheffield University and King's College Clinical Trial Unit to do an at-home test for bladder cancer. And what we found was, by deploying these kits into people's homes, they were much more likely to engage in those screening programs and actually do that screening. I mean, they were all men. They were all over the age of 65, and they were all in Yorkshire. So for me, I call that a 3-level stoic population. They're really difficult to engage in screening services. They're really difficult to get into clinical settings. And we were able to send these kits out to people. We were able to put that test at point of need. Yes. And they were able to do the test at home, but those results were being provided centrally to study nurses to be able to determine what the right next step is for them within their screening pathway. Yeah. So they're not being asked to the home user isn't being asked to understand what the results are. They're doing the test, and we look after the integrity of the result, and then those results are delivered to clinical professionals who are able to manage that patient population. And all through the platform that you've developed. Yes, absolutely. And what it means is you're able to deal with a much larger screening population. You're not trying to always pull people through clinical settings. Yeah. Massively reducing footfall, improving the experience for people, yes, for individuals within their own homes, and providing clinical professionals with the tools they need to make things better. Yeah. Now, that model, we've then developing that model for prostate cancer at the moment. We're working with Mid and South Essex Trust
Right.
to produce a new model for different prostate cancer screening, where kits can go out to people's homes. They're able to do the test under their own steam, with no one looking over their shoulder. Men are really bad at going into clinical settings and admitting something's wrong or doing the right, but they're very good at adopting new technology and doing things under their own steam in privacy and security of their own home. So we can ask them to do the test. Those results then go centrally, and the decision can be made as to what the right next step is within their screening. So we get an access to a much larger group of people.
Yeah.
I mean, we know for prostate cancer, for example, that when letters go out to high-risk populations, say, please come in for screening, only around 30% of those. And in some populations, and they're invariably the populations that are a higher risk, it's only around 20% that people actually answer that letter and come in. Now, there's a really good survival rate up to stage 3 in prostate cancer, whereas once you get to stage 4, it drops off massively. Yeah. So prostate cancer kills more people than any other cancer other than lung and bowel, and they affect everyone. Whereas prostate cancer only affects men. It still kills more men. Wow. Breast cancer used to kill more. It doesn't anymore. And a lot of that is to do with access to screening and increasingly talking about it and becoming something that people do talk about and improving the communication and knowledge about it. And I think we can do that with prostate cancer.
Brilliant. Well. Yeah, brilliant. It seems like a really worthwhile thing to do, not just obviously, the saving lives element, but I guess the impact on the NHS as well.
Access to tools, but also for the services to be able to access people.
Yes.
People are much more likely to engage with something that lands on their doormat, where they're not having to take time off work.
Yes.
They're not having to sit in front of someone and ask what's wrong, or they can do it within the comfort, convenience of their own home. But using something that mobile phones have become a big part of people's lives. They're almost an attachment for them.
Yeah.
And you've got a huge amount of real estate that you can communicate with people through on a mobile phone, rather than just sending out a letter, which is still how, in many cases, these screening services are. You get a letter through the door.
Yeah.
Don't even look at my mail.
No, that makes so much sense. So Andrew, I mean, we know that the NHS is in a bit of a challenging time at the moment. I'm sure you've read the Darzi report around this. You might have also heard West Treating talking about sort of similar things. We want to go from analog to digital. We want care more in the communities. And all of those things, it appears to me that, TestCard kind of supports. But equally, obviously, it is still a challenging environment, specifically financially and commercially in the NHS. How do you feel about scaling TestCard from where it is now to the future in this current environment?
It's difficult. I think it's always been quite difficult within the NHS in understanding what is a saving. I mean, you've been a senior manager in the NHS. I've been a senior manager in the NHS.
Yes.
And in some respects, the fact that you still work on a 1-year budget, and the fact that you still have primary care and secondary care as 2 separate budgets, and the fact that savings are counted by what the number looks like at the bottom of a column, I think it's getting better at it.
Yes.
But I think the more we can recognise deferral of future spending, is recognising, actually, if we carry on the path we're on now, this is going to be this much more expensive than it is now. Yeah. So if by spending a little bit now, which will increase the costs at this moment in time, but it will save money in 2 to 3 years' time, things will get better.
Yes.
And I think if we can truly recognise bed savings, for example, we talk about bed days in hospitals quite a lot, but you can never point at a bed that's empty because of something that you've done. So it's finding ways of counting improvements and savings and efficiencies within the system that isn't just about reducing that bottom line number of cost.
Yeah.
And again, it's easy for me to say that without telling me how to do it.
Yeah.
But I think that's always been the difficulty in getting into the NHS as an external company, because they always want to see a case study with the economic healthcare model that looks like this. Mm-hmm. It looked like this before, and this is what it looks like now, and that number at the bottom is smaller than the number that was at the bottom before. Yes. And in order to get that economic healthcare model, though, you have to have been adopted somewhere to get it.
Precisely.
But you can't get adopted somewhere until you've got that economic healthcare model.
Yes. So
it's something of a catch-22.
I was just going to say, absolutely. How interesting. And how did you make that happen for yourself? You've also got sort of some really good partnerships as a company. You've got a partnership with Roche and various other test providers as well. How did you get TestCard to a place like that? As a startup at one point in time.
Perhaps we've just been lucky. It's an overnight success, isn't it? It's always an overnight success. No, we've been going for a long while, and I think there's a certain amount of credibility that comes from being sticky. The fact that you haven't just come in and you've only just turned up. I think working with health bodies especially, they like to see that you have longevity and stability, because they don't want to start using you and then it fail.
Yeah.
We were very fortunate with Roche that we got on an accelerator program quite early, startup cryosphere program, in which Roche was a sponsor, and they saw the benefits of what we were doing. And then when they were producing their new Cobas Pulse, a new glucometer, we were one of the first people they asked to go on it with the technology. So that's been very fortunate. But then because we've got that sort of co-branding with Roche there, other people then are more willing to speak to us. So it's a little bit of a domino run. Is that once things start going well, they continue to go well. The more relationships you build, the more relationships you have.
Absolutely. Lots of exciting things happening at TestCard, especially with this prostate cancer screening kit. What would you say are your sort of top 3 objectives in the next 6 to 12 months? What would you like to achieve?
So for me, the company was built initially on this idea of being able to do prostate cancer screening at home.
Yeah.
If we achieve that, I actually get a bit emotional about it at points, to be honest, when I'm talking to members of staff and in our company about what we're going to achieve here. In and of itself, it's an incredibly valuable thing to be able to deliver and to be able to offer that tool to the NHS, but also to be able to offer that access to that sort of screening to people generally.
Yeah.
If you consider, like I said, only around 30% of people take up screening at the moment, what percentage do we need to get to where we're actually making a big difference? And it's not a high percentage. We don't need to see a big improvement for it to make a huge difference in survival rate of prostate cancer and identifying those cases. But I think what's key with TestCard is, as much as prostate cancer is an amazing thing to be doing this within, what we're proving is beyond that. It's a new model. This new idea of being able to, instead of moving people, moving information. And I say information rather than data, because they are different
Two different things indeed.
And it's, once we've proven that model outside of a trial, that can be applied to any number of other conditions.
Yeah.
We can do this for diabetes. We can do screening and monitoring of HbA1c testing in people's homes. So you have a chronic condition where they regularly need to be checked. Quite a lot of those people don't meet the time periods in which they're supposed to have their screening every 3 months. Well, part of that is because they're having to take time off work. They're having to go to GP surgeries. The GP surgeries themselves are trying to, as well as dealing with emergent conditions and general people primary care, is managing those chronic conditions. A lot of this outpatient chronic conditions can be managed within people's homes. And the key thing for me is this model doesn't reduce or doesn't detrimentally affect the experience of the people involved in it. In many cases, when you try and push things out, what happens is the individual who has their healthcare being done feels more separate and feels left alone more. Whereas this actually, it engages them more within their healthcare. It empowers them more within their disease, within their health conditions. Gives them a better understanding of what's going on.
So there's an education element.
Yeah. So I feel that it massively improves things on both the individual side and on the clinical provider side.
Yeah.
And that's a rare benefit of these sort of changes.
Yeah.
So it's a model that we can apply to any number of other situations.
Brilliant. Looking back on your journey, as you say, you've been here a while now as TestCard. Is there anything you would do differently?
Oh God. Maybe. I think I've learned an awful lot. And as a startup, you spend a lot of your time chasing leads, and some of those develop and some of them don't.
Yeah.
But for each one that doesn't, you learn something from it, and you move on with more knowledge than you had before and better understanding.
Yes.
So I'm not sure there is really, because we wouldn't be where we are now without all the mistakes we made on the way to get here. Failing, again, going back to failing, but learning from that failure and making that failure safe.
Yeah.
And then continuing on with more knowledge than you had before.
And on that note, I guess my last question for you, Andrew, is for the sake of the next generation of innovators, if they are starting off today, they've got a great idea, what would your advice be to them, and where would you want them to start?
Have a co-founder.
Yeah.
Definitely. Don't try and do it on your own. It doesn't matter how much energy and how motivated you are, you will run out at some point. But also, what you find when you have a co-founder is you always have a platform to bounce off of. You know, they're the only person that will turn around to you and say, that's not right.
Yeah.
It's not what we should be doing. Understand why you're doing it, because sometimes you lose track of what you're doing. Yeah. And it's important to understand why you're doing it, to make sure that you can keep going, so you do get up that one more time than you get down.
Oh, that's fantastic. Thank you so much for your time today, Andrew. It's been fascinating.
It was great being here. Thank you for having me.
Thanks once again for listening to this episode number 3 of the Inside Health Innovation podcast. We really hope you enjoyed it, and don't forget to like and subscribe to our podcast so you don't miss any of the episodes. We really look forward to seeing you next time.